Hello everyone. Let us now discuss viral infections in children. We'll be doing it in an integrated manner but focusing more on the clinical aspects rather than the routine, bland way of teaching. So let us begin with the first important viral infection, that is measles. So what are the points that you need to remember regarding measles? First of all, measles is a viral infection caused by the etiological agent. The etiological agent or the causative agent is virus, which is single-stranded RNA enveloped virus. It is a single-stranded RNA enveloped virus belonging to paramyxovirus family. So it belongs to the family called as paramyxovirus family. MCQ on this has been asked in your microbiology part. The second thing that you need to remember is the source of infection. Source or root of infection. Now remember that measles, there are no subclinical cases and there is no carrier state. The source of infection is always a active case, and person to person transmission from active case to other suspected individuals occurs through the respiratory route, that is droplet infection. So there are active cases which cause spread of infection. They cause spread of infection through droplet route. So droplet route, that is respiratory secretions, are the primary mode of transmission of the virus. And you can put a star and write the another MCQ related point, also a viva point. There is no carrier state in patients with measles. So this is something you can add as a standalone point. The third thing is secondary attack rate. You have read about secondary attack rate, right? Measles is a highly infectious condition and the secondary attack rate ranges between 80 to 95%. Fourth thing is the incubation period. The incubation period varies between 8 to 12 days. Nelson gives a value of 8 to 12 days. O.P. Ghai says a median value of about 10 days. So 8 to 12 days is the incubation period. And finally, what is the period of infectivity? The period of infectivity is 4 days before to 5 days after the onset of rash. So 4 days before to 5 days after the onset of rash. Now coming to the clinical manifestations of measles, how the measles virus tends to affect. Now whenever there is an infection by measles, initially the measles virus enters into the respiratory tract. It not only causes infection of the respiratory cells and the respiratory tract epithelium, but also causes viremia and spreads to various other types of cells. You need to remember that measles virus enters cells through two types of receptors. The first receptor is CD150 receptor. Through CD150 receptor, the measles virus enters into the non-pulmonary cells. So non-respiratory or non-pulmonary cells, it enters via CD150 receptor. And the second thing, it is an extra edge thing we are talking, given in Nelson, new thing in Nelson 21st edition. And second thing is, the second receptor is PVRL category 4 or PVRL4 receptor, which is also called as Nectin-4 receptor. It is through this receptor that the virus enters the pulmonary or the respiratory tract cells. So after this entry into the cell, there is viremia, there is infection of various organ systems, and there is onset of constitutional symptoms including fever along with the characteristic rash appearing a few days. How would you identify what is the clinical course of the disease? So after an incubation period of 8 to 12 days, on day 1, day 1 means the day the disease becomes clinically symptomatic. On day 1, there is onset of fever. So fever comes on the first day in most cases. Along with that, it is associated with prodromal symptoms characterized by 3 C's. So fever के साथ में there are always 3 C's which are happening. What are these 3 C's? One is cough, second is coryza, that is increased nasomucosal secretions, and conjunctivitis. Very, very important. Potential MCQ. Remember that conjunctivitis is present in more than 95% cases as a prodromal symptom before the onset of rash. So 3 C's along with fever appears on day 1. Then on day 2 or day 3, second or third day after the onset of fever, fever continues for few days. Then day 2 or day 3, there is onset of enantheme. What is enantheme? Now you would be coming across exantheme and enantheme. Exantheme is a rash on the skin, whereas enantheme is an eruption occurring on the mucous membrane. So mucosal rash or mucous membrane eruption is called as enantheme. So enantheme will occur. Where will enantheme occur? The most common site is the buccal mucosa. So enantheme occurs on buccal mucosa, and the characteristic lesion seen in these children is called as Koplik spots. The most common thing regarding Koplik spot is the commonly asked question on which at least as far as I can remember 3 to 4 times it has been asked in last 10 years in MCQ entrance. What is the first site or the most common site where Koplik spots appear? The Koplik spot first of all appear on the buccal mucosa opposite second lower molar teeth. And later on, they may involve other parts of buccal mucosa as well. They may involve the lips also, and they may involve tongue as well. So the first site of appearance is buccal mucosa. And how does Koplik spot look like? They are bluish white like sands of grain and surrounded by surrounding erythema in them. After the onset of Koplik spots, usually 24 to 48 hours later, that is around day 4, you have onset of rash. So the measles rash typically comes on day 4, and the rash is described as it is a erythematous, that is red colored, maculopapular rash. So there are macules and there are papules. Erythematous maculopapular rash. This rash starts from the face, that is forehead and behind the ears, then spreads to trunk and then spreads to limbs. And it tends to resolve in about 7 to 8 days. It tends to resolve in 7 to 8 days. Sometimes it may leave behind a brownish or brawny hyperpigmentation at the back. So this is the typical pattern of rash which is seen in patients with measles. And so the total duration from the onset of fever to the disappearance of rash is usually around between 7 to 10 days. That is the total course of measles, unless it is complicated, unless there is some coexisting problem. So if I have to show you a picture, this is how the measles rash looks like. It starts on the face and forehead but is more prominent and discernible once it appears on the trunk, and in the front of the chest also, in the back also, and very few children tend to develop it on the distal extremities. So fine maculopapular rash, this rash is non-itchy. It is a non-itchy rash which is seen. So unless any rash which is itchy, I will be mentioning it separately. If it is not mentioned, that means that rash is non-itchy in this entire discussion. And this is a photograph showing Koplik spots. Just look at these Koplik spots. Can you see these bluish white grains of sand appearance? This bluish white gray of sand appearance with surrounding erythema is called as the Koplik spots. They are the pathognomic sign in patients with measles. Now moving over to the complications of measles. The most common complication of measles is acute otitis media. Most common cause of death in measles is pneumonia. Remember that pneumonia in measles can be caused due to measles virus itself. This pneumonia due to measles virus itself causing pneumonia is called as primary giant cell pneumonia. It is also called as Hackett's pneumonia. And second, pneumonia can occur because in measles it is seen that the immunity of the body is somewhat lowered. Measles virus also causes infection of the lymphocytes, particularly the CD4 T lymphocytes, and so the helper T cell response is impaired, leading to increased infection by various other pathogens. So measles is an infection which produces a partial immunocompromised state. So pneumonia can occur due to other bacteria or secondary bacterial infections as well. For example, pneumococcus, H. influenzae, Streptococcus pyogenes, Staph aureus, they all pneumonias can happen. And remember, the secondary bacterial infection are more common than the primary measles virus induced pneumonia, and pneumonia is the cause of death. Overall, most common complication is acute otitis media. What are the other complications which can be seen? The other complications include diarrhea, reactivation of tuberculosis, and there was a thing called as black measles. This entity is no longer seen, or it is a hemorrhagic kind of manifestation where large tense bleeding bullae tend to form on the body, and hemorrhagic black measles usually has a high mortality. However, it is not a very common condition these days, and it is more commonly seen in children who have coexisting immunocompromised state as well. So these are the other complications. And finally, you have a rare, fatal, and chronic complication. The most severe or chronic or life-threatening complication, fortunately, which is rare, it is SSPE. SSPE stands for subacute sclerosing panencephalitis, which tends to occur many years after measles infection has come and gone away. More about SSPE we'll discuss separately. It is one of the hot topics for your entrance exam, not properly covered in most of your texts, whatever text you read. So we'll be talking about SSP separately. These are the complications. And coming to treatment of measles virus, treatment in most patients is always supportive. Plus, extra edge thing, Nelson 21st edition says, as well as our national health guidelines say, that vitamin A supplementation needs to be given in all children with measles. Children with measles tend to develop low circulating levels of vitamin A, low hepatic stores of vitamin A, and conversely, vitamin A deficiency in measles is associated with increased mortality. So, vitamin A supplementation needs to be given in all children. The schedule is virtually the same what you read for vitamin A suspected diseases, but remember that vitamin A supplementation is given for 2 consecutive days in all patients with measles. Less than 6 months of age, 50,000 international unit. 6 months to 1 year, 1 lakh international unit, and above 1 year, 2 lakh international unit given on 2 consecutive days. That is the vitamin A supplementation. I am not writing it here because this is something we have discussed in nutritional diseases wala part. So, vitamin A supplementation is mandatory. Plus, potential MCQ. Is there any other agent which may have a future role? The answer is yes, ribavirin. Studies have shown that ribavirin is effective against measles in vitro. However, it is not yet recommended for the treatment of measles infection. Maybe in a few years down the line, recommendations may come. Ribavirin shows good activity against measles other than RSV and other infections, but it is not yet recommended. Not yet any recommendation is there for ribavirin use. And before we finish off, remember, prophylaxis can be done using your isolated measles vaccine does not come. It comes in the form of a MR vaccine now, measles and rubella vaccine. 9 months and 15 to 16 months is the time during which the primary doses need to be given, followed by booster at 4 to 6 years. And in case of exposure to measles in a susceptible individual, you can always use measles immunoglobulin. However, it is not needed in majority of cases. So this is regarding measles, and before we finish off measles, One standard one-liner taken from pathology can be asked in MCQ because we are doing it in an integrated manner. So I don't want you to leave out any important thing here. So if somebody asks you what is the pathological hallmark of measles infection, one-liner, remember it is Warden-Finkelday cells. Warden-Finkelday cells. They are nothing but multinucleate giant cells which are formed in tissues affected by measles virus. So this finishes measles. Let us talk about the related hot topic SSPE, subacute sclerosing panencephalitis. SSPE stands for subacute sclerosing panencephalitis. So SSPE is a rare complication, as I have said before, but if it happens, it is usually fatal to the child. SSPE, what is the most common age group during which it affects? Harrison 20th edition says more than 85% children are between 5 to 15 years of age. Once the SSPE tends to manifest 7 to 15 years after measles infection. But once it manifests, it is rapidly fatal in 1 to 3 years. To give you an example, a typical case scenario will be a patient had measles at 1.5 or 2 years of age, unimmunized child, 2 years of age measles hua. SSPE will manifest somewhere around 9 to 10 years of age, more than 7 years later, right? But once it begins, it will cause death in the next 3 years. So the child will not survive beyond 12 to 13 years of age, except if some very good supportive therapy is given to the child. So this is the timeline of development of SSPE. What are the stages of SSPE? There are 4 stages which are defined. Stage 1, there are subtle behavioral changes. Stage 2, there is onset of myoclonic jerks. It is caused by infection of measles virus in the CNS, in these neurons. So myoclonic jerks. Stage 3, there will be onset of abnormal chorioathetoid movements along with rigidity. And stage 4, the patient will move into vegetative stage, that is coma will develop and death will develop. There will be failure of the vital centers of the brain. So these are the 4 clinical stages defined for SSPE. How do you make the diagnosis? The diagnosis is based upon, earlier they used to do brain biopsy, but these days brain biopsy is not recommended. Now we make diagnosis based upon presence of measles specific immunoglobulins, that is antibodies, in CSF. So we look in CSF, measles specific immunoglobulins in CSF with or without evidence of past measles infection. With or without evidence of past measles infection, which may be in the form of antibody titers, or there may be a history suggestive of active measles infection occurring in the child. And to increase the predictive value, we perform EEG, which shows characteristic changes suggestive of SSPE. So the obvious question arises, and all these criteria, these diagnostic criteria are put into a system called as Dykers criteria. If somebody asks you, details will not be needed for NEET PG, but remember, if somebody asks you, is there any named criteria for diagnosis? It has major, minor, supportive criteria. It is called as Dykers criteria. Just the name पूछा जाएगा, other details will not be asked at your level. And what will EEG show? EEG in these children will show the presence of periodic high voltage, sharp and slow wave complexes, which are called as potential MCQ Rader-Macker complexes. Rader-Mecker complexes. The word is important. And what is the therapy for SSPE? For patients with myoclonic jerks, you can use carbamazepine. Now, this is very interesting. If you read neurology, you would know that carbamazepine worsens all myoclonic epilepsies. But ironically, SSPE myoclonic jerks only respond to carbamazepine. So, as a supportive therapy, it is added in all patients. And there is a new treatment regime which is now available, which uses a combination of two drugs. We use isoprenosine along with intrathecal means into the CNS, into the CSF, intrathecal interferon alpha therapy. And this treatment regime has improved the survival by many years. But eventually, the disease has a very high mortality. So, this is regarding SSPE. You may get a case, you may get treatment regimes, or you may get simple one-liners based upon Dicus criteria, Rader-Mecker complex, seen in which condition, related to which condition. And just as an anecdote, I hope you know this guy. Unless you are not interested in any web series or medical series, you would know him. So he is Dr. Gregory House, that's his screen name. In the series House, season 1, episode 2, there was a patient, there was a case with typical manifestations of SSPE. So if you have time and you just want to chill out, watch something which also has academic value, do watch that episode of House series, season 1, episode 2. The final diagnosis there was SSPE. Of course, for movies, for series, they always say interferon alpha was given and the patient got fine. But usually, patients have a very poor outcome in SSPE. Next, we come to rubella. Rubella is also called as German measles. So, German measles does not mean measles, it basically means rubella. What is the etiological agent? It is caused by a single-stranded RNA virus belonging to Togaviridae family. So, the virus belongs to Togaviridae family. MCQ point. What is the incubation period? The incubation period is 14 to 21 days. What is the mode of spread? The mode of spread of rubella is through the droplet route, that is respiratory secretions. So, droplet route, it spreads from person to person. In bracket you can write respiratory secretions. And what is the period of infectivity? The period of infectivity ranges from 5 days before to 6 days after the onset of rash. So, we define all these periods in relation to the rash. Now, what is the clinical manifestations of rubella? So, what are the clinical features, the presentation of rubella? Initially, there is once the incubation period is over, the child has low grade fever, which may sometimes even be absent, along with prodrome comprising URI-like symptoms. The key point to remember here is there is no conjunctivitis. This is very important. There is no conjunctivitis. Conjunctivitis will be present as a prodrome in case of measles. After this, 3 days later, there will be onset of rash in the child. And the rash is in the form of bright pink macules. Sometimes papules may also be present. So, bright pink macules or maculopapular lesions. So, they will be bright pink in color. They will start on the face and the neck, then they will spread to trunk, and then they will spread to the limbs. The key point to remember here is as rash goes from face and neck to the body, the facial rash tends to disappear. So, the whole body is never involved together. So, in bracket you can write that facial rash disappears as rash moves distally. And each portion where the macules have appeared, overall it tends to improve in another 3 days. So the patient improves in another 3 days. Because the rash is coming in 3 days after fever and disappearing in 3 days, whatever sites they are coming. Once the progression is completed, the rubella infection tends to become passive, usually with a period duration of 7 to 10 days again. So that is the total duration of rubella in uncomplicated cases. Because 3 days and 3 days are there, so rubella is also called as 3-day measles. So older name of rubella is 3-day measles. So German measles is also rubella, 3-day measles is also rubella. And if I have to show you a picture, this is the fine bright pink macule rash which is present in patients with rubella. Now, rubella, you need to remember some key words. Some key words are important. What are the key features of rubella which will always be mentioned in patients when you get a rubella case? The key features along with what we have discussed. First is, rubella always has lymphadenopathy. Lymphadenopathy typically involves 3 specific sites in rubella. One is retroauricular, that is behind the ear. Second is posterior occipital. And third is anterior cervical. And lymphadenopathy usually appears along with fever. The second key feature is lesions on the soft palate. Rubella has lesions appearing on the soft palate in most cases. And lesions on soft palate are of 2 types. There may be pink macules on the soft palate. These pink macules are called as Forsheimer spots. So what are Forsheimer spots? They are pink macules appearing on the soft palate. And sometimes these pink macules may evolve into or may be coexisting with hemorrhages on the soft palate. So hemorrhages or pink macules on the soft palate are another key feature, and these tend to appear along with rash. So if a MCQ says 1.5-year-old child, unvaccinated, unimmunized, has fever, rash which begins on face, rash is non-itchy, associated with prominent lymph nodes bilaterally behind the ear and some lesions on the soft palate, immediately your mind would think of rubella. There is no other diagnosis. In clinical MCQs, look at the keywords. See, all these infections you have read multiple times in microbiology, medicine and PSM, and the point I am making here is focus on the keywords, what will help you in solving MCQ, what will help you in telling the examiner in case of a practical thing. So these are the key features you must always remember. Now moving over to the complications of rubella. Complications are usually mild. It is a milder illness as compared to measles, and most patients who tend to develop complication, they have mild thrombocytopenia, which is usually asymptomatic and lasts for around 2 weeks according to Nelson. Older patients or adolescents, sometimes even adults who get rubella infection if they are unimmunized, they will have arthritis or arthralgias. And very rarely, particular bad luck is there, mainly immunocompromised, you may develop a progressive rubella illness called as PRP, which is a fatal condition. PRP stands for progressive rubella panencephalitis. It is a SSPE-like illness. Treatment in rubella is supportive. But pregnant females, you should be very careful about managing them, and in fact, proven rubella in first trimester is one of the indications for medical termination of pregnancy. And obviously, vaccination part we have already done. In the vaccine segment, rubella can be prevented through the measles rubella vaccine, which also has rubella component in that. So this finishes our second viral infection, that is rubella, from a clinical pediatric point of view. The next infection is chickenpox, also called varicella. Etiological agent, it is caused by a double-stranded DNA virus. So the previous two were RNA. So double-stranded DNA virus belonging to herpes family. The name of the virus is, as already written here, it is varicella zoster virus. So it belongs to herpes virus family. What is the incubation period for chickenpox virus? OPG gives a long range ranging from 10 to 21 days, whereas Javet's microbiology as well as Nelson say that there is a median duration of about 16 days. So it lies somewhere in between. So 10 to 21 days if the question says range, if the question says single value, median value of 16 days. For 14 to 16 days is what is written in many books. What is the secondary attack rate? Again, secondary attack rate is high in patients with varicella. It is as high as around 80%. And chickenpox virus, what is the period of infectivity? The period of infectivity ranges from 48 hours before rash till, now rash has a progression as macule, papule, then vesicle, and vesicle finally heals by crusting. So 48 hours before rash till all lesions in the child have crusted. That is the period of infectivity. Now MCQs mein they won't directly ask you period of infectivity, they will give you a case. A child developed chickenpox who was not immunized for varicella vaccine. The child was segregated and kept in isolation. After what time the child will be safe to be sent to school? 4 options will be there. The answer to this question will be once all lesions have crusted. So that is the time the period of infectivity ends. So these are the 4 points that you need to remember. Now moving towards the clinical features of chickenpox. So what is the clinical manifestation of chickenpox? Initially, first of all, again, just like any other viral infection, there is a viral prodrome comprising fever, which is moderate grade, neither as high as measles nor as low as rubella, somewhere in between 100-101 degrees Fahrenheit, along with URI-like symptoms and anorexia. Some patients may also have headache and night sweats. So viral prodrome will be there. 24 to 48 hours later, there will be onset of rash. Now rash in these children typically begins in the form of macules, non-palpable. Then they turn into papule in a few days. These papules evolve into vesicles. Vesicles are fluid-filled lesions, and these vesicles develop crust and heal. So this is the normal progression of rash. Rash is very characteristic. There are few points about rash that you need to remember. The first point about rash is always itchy. It is a very itchy rash. Both the previous rashes were relatively non-itchy. It is a very itchy rash. Secondly, rash appears first on the trunk with or without face and then spreads out. That is, later on it spreads to the limbs. So rash first appearing on trunk or face and then spreading out, this pattern is called as centripetal rash. So one of the characteristic example of centripetal rash is chickenpox rash. Thirdly, the rash tends to occur in crops. Crops means a lot of macules will appear at one place. In next 2 or 3 days, they will turn into papule, vesicle stage and so on. Then another set will appear, then another set will appear at a separate place. So it occurs in the form of crops. So closely aggregated lesions. And the same person may have different types of lesions at the same time. To give you an example, what this line means. This line is mentioned in Ghai, but students don't understand the relevance of that. So the concept here is, suppose I get chickenpox. So what will happen is, today is Friday, I am recording on a Friday. So today on Friday, I will have some macules here. Suppose I get rash today. So I will have a lot of some macules here, some here, some here. They will all be itchy. In the next 24 to 48 hours, these macules will evolve into papules, and later another 24 to 48 hours, they will turn into vesicles. They will be filled with clear fluid. In a few days, while this is happening, another set of crop lesions will appear here and maybe on the face. And another few days later, some will appear on the limbs. So rash is starting here and moving towards the periphery. And when you see me on on rash started on Friday, maybe you see me on Wednesday, you would find that this part has vesicles because lesions have evolved. This part has papules and this part only has macules because the lesions have just started. So the same person is having vesicles also, papules also, macules also, different crops at the same time, and some may even start crusting. So that is called as different types of lesions present at the same time in the same individual. Very useful clinical clue, can be asked in entrance exam. This is one of the bases. Itchy rash and the type of progression is how we make clinically the diagnosis of chickenpox in case of children. And the vesicles, they are filled with a clear fluid and they have a surrounding erythema or redness around them. So that vesicles give an appearance as if drops of dew are present on rose petals. So we call it as dew drops on rose petal appearance. Dew drops on rose petal appearance. And then rash tends to improve, rash tends to heal with some hyperpigmentation or scarring. Remember that hyperpigmentation or scarring is more common in older children and adolescents and adults as compared to young children. Young children, it does not leave any hyperpigmentation or scars. Older children, the infection tends to be relatively more severe. The chances of scarring is relatively more. And if I have to show you a picture of chickenpox or varicella, these are the lesions. There are some macules, there are some vesicles. These vesicles are present in this patient. Obviously, just looking at a spotter, you cannot make the diagnosis. You need to have some clues which will always be there in a clinical case. After the clinical features, let's talk about the complications of chickenpox or varicella infection. The most common complication are secondary bacterial infections. Another common complications are the CNS infections, in those in which it gets complicated. CNS complications include acute cerebellar ataxia, which is usually self-limited. Acute cerebellar ataxia has been asked in one of the MCQ entrance exam in the past. Some children may also develop encephalitis. Many children tend to develop purpura fulminans due to antibody formed against protein C. And Ray's syndrome can also develop if these children are treated with aspirin, when fever is given with aspirin. For fever you give aspirin in the child. So these are the common complications, but overall the complications are rare compared to measles. Coming to therapy, now the drug of choice in varicella infection is acyclovir. But remember, according to American Academy of Pediatrics, the app guidelines say that in a less than 12-year-old child with no risk factor, that is, the child is not immunocompromised or malnourished, and mild illness, needs no drugs. That is, only observation is recommended. Only in older children or children who have features related to any complication or complication can be suspected, in those children you will use acyclovir. So acyclovir generally is seldom used in these patients. Potential extra edge thing, if the patient has acyclovir resistance, this can happen in children who are HIV positive and those who develop chickenpox infection. In these children, the next drug to be used, you can use either foscarnet or cidofovir. They are the two options in acyclovir resistant HIV positive individuals. And of course, there is a vaccine now available for the prevention of varicella zoster infections. The next disease is called fifth disease. It is also called as, the technical name for this, that is erythema infectiosum. Not many details need to be done. So we will only stick to what you bare minimum need to know, what can be asked in your entrance exam. So the fifth thing is, what is the etiological agent? It is caused by a double-stranded DNA virus called as parvovirus B19. So parvovirus B19, which is a single-stranded DNA virus, one of the very few single-stranded DNA viruses, parvovirus B19, it causes erythema infectiosum. The second thing is, what is the age of affectance? Fifth disease occurs between 5 to 15 years of age, although rare cases may occur in adulthood as well. Route of transmission, it is the respiratory route, that is, droplet method is through which the infection tends to spread. Coming to the clinical features, the clinical features are very characteristic. There is initially an incubation period of ranging between 4 to 28 days with a median value of around 16 days. After that, the first manifestation, initially there is fever along with prodromal symptoms. The usual URI-like symptoms, irritability, etc. After onset of fever with prodrome, 1 to 2 days later, there is onset of rash. The rash first appears on face. The classic appearance is slapped cheek appearance, potential MCQ. Slapped cheek appearance. It is a red-colored maculopapular rash which appears bilaterally symmetrically on both the cheeks. So if I have to show you a picture, this is where the rash occurs. So as you can see, erythematous maculopapular rash is present on bilateral cheeks where slaps are put. Everybody has been slapped, so we all know this is the area where rash appears. Rash tends to improve on the face and then spread to the trunk and limbs. On trunk and limbs, it initially starts as pink colored macules. These macules show central clearing, and central clearing produces a reticulated or lacy pattern. And overall, the disease tends to improve in 1 to 3 weeks. Treatment needed is only supportive. Diagnosis is based upon the typical clinical presentation. If somebody asks you complications, complications are rare, but complications can happen. The common childhood complications include ITP. So acute thrombocytopenic purpura can occur in these children. There can be aseptic meningitis, and there can be arthralgia or arthritis, pain or inflammation in the joint. But most of them are manageable and rare. So this is regarding fifth disease. And finally, we come to sixth disease. Sixth disease is also called as two alternative names, roseola infantum. Roseola infantum, rose-like, like red to pink colored lesions present in infant, so younger age group, also called as exantheme subitum. These are the two alternative names of the same entity. What is the cause? What is the etiology? The most common cause of sixth disease is human herpes virus 6 virus. Other common causes include human herpes virus 7. It can also occur due to ecovirus 16. What is the clinical manifestation or clinical features? The incubation period in sixth disease is variable. In various books, it has been mentioned as ranging from 1 to 5 weeks. So it is not something which will be mentioned. That is why O.P. Ghai and many textbooks are silent upon these. Even Nelson is silent upon these. So no need to remember. Clinical features are characteristic. There will be high-grade fever at the onset along with viral prodrome. So constitutional symptoms or URI-like illness will be there along with high-grade fever. This fever will last for 3 to 4 days. Then as fever comes down, as fever subsides, within 12 hours of fever becoming passive, there will be onset of rash. So rash comes once the fever goes away. MCQ on this has already been asked. If you look at past MCQs, one such question is also there in the question bank. So within 24 hours of fever going away, there is onset of rash. Rash, just like you had varicella rash, it first appears on the trunk and then spreads to face and limbs. But it is not the rash, the pattern being same, the morphology of lesion is different. It is in the form of pink or red macules. Very rarely there may be maculopapular rash, and it is a non-itchy rash. It is a non-itchy rash. There is no itching and there are no vesicles. So you can easily make out that this is not chickenpox rash. And rash again tends to resolve. The rash tends to resolve in 1 to 3 days. Any characteristic lesion? Yes. Many of these children are found to have, when the rash comes, they are also found lesions called as Nagayama spots. Old NEET MCQ, old NEET PG question has been asked on where is Nagayama spot seen? What is the condition? The answer is sixth disease. Nagayama spots refers to ulcers or aphthous ulcer-like lesions occurring at uvulo-palatoglossus junction. And treatment in sixth disease is supportive. Now, there are two things before you need to remember before we move to the next viral infection. Among all the rashes in viruses which we have discussed, there are only two rashes which appear majorly, which appear on the trunk first and then spread to the peripheries. One is varicella, second is sixth disease. Varicella will be a itchy rash and it will show progression of lesions will occur in crops, whereas sixth disease will be a non-itchy rash, there will be no vesicles and there will be no crops occurring in that. And the other remaining rashes are usually non-itchy and the progression is very similar to them. Second thing that you need to remember is there are two rashes which show oral mucous membrane characteristic lesions. If question says the patient is having pink macules or hemorrhages on the soft palate, then we are talking about rubella infection. For Scheimer spots and its coexisting lesions we are talking about. If the question says ulcers on uvula and palatoglossal junction posteriorly, then we are thinking of Nagayama spots and then sixth disease will be the more likely diagnosis. So these are the key words that you need to remember when you prepare for entrance exams. The next viral infection we shall be discussing is mumps. Mumps is a viral illness which is caused by a virus belonging to the paramyxovirus family. So the virus belongs to paramyxovirus family. Mumps is again highly infectious condition with mode of infection or route of infection being the droplets. That is, respiratory secretions are the predominant mode of infection. What is the incubation period? Incubation period is 2 to 4 weeks. If we talk about the age group, mumps is one infection which occurs across all ages. Although it is very rare to be seen in infancy and again rare to be seen beyond 40 to 50 years of age, but cases do occur in adolescents and also in adults. If question asks you what is the peak age for mumps virus infection, so peak age for mumps infection to occur is 5 to 15 years of age, and this is your past JIPMER MCQ already asked, so can be repeated in future exams as well. So peak age for mumps is 5 to 15 years. What is the period of infectivity? The period of infectivity, now mumps does not have rash. So the previous infections which we discussed, we were telling the period of infectivity based upon rash. Here there is no rash, it is the parotid swelling which is the predominant feature, and so we define period of infectivity based upon the swelling as the landmark. So period of infectivity is defined as 6 to 7 days before to 7 to 9 days after onset of swelling. Since it is very atypical from what we have done so far, can be asked in entrance exam. The secondary attack rate in case of mumps is 60 to 80%, which is fairly infectious. But remember, it is a statement based question asked in old AIMS entrance that one attack of mumps provides lifelong immunity. There was an old question which said, identify the incorrect option regarding mumps infection. One of the option was, repeated attacks can occur later in life if the patient is not immunized. That is wrong. Repeated infections do not happen. One attack confers lifelong immunity, and if the patient is immunized, obviously there will be no mumps infection. So this is regarding the initial things, what have been asked in the allied things, other related subjects related to mumps, since we are doing it in an integrated manner. Now let us focus on the clinical aspects, clinical presentation of mumps. The clinical presentation of mumps is very characteristic. So clinical features, mumps after an incubation period of 2 to 4 weeks, mumps presents with fever along with painful parotitis. So parotid gland inflammation and enlargement is the hallmark of the disease. So there is fever along with painful parotitis. So painful parotitis, there are few things regarding this that you need to remember. So parotid gland is enlarged, inflamed. Remember that unilateral parotitis is much more common than bilateral parotitis. So usually it produces a unilateral swelling on one side of the neck. It occurs below the ear region and may sometimes cause difficulty in opening of the mouth. It will be painful and it will also interfere with chewing action of the child. In additionally, it will also cause dry mouth and can cause difficulty in chewing as well as swallowing. Difficulty in chewing because it is painful, so the masseter action becomes painful, it is compromised by the child. And swallowing is difficult because of the dry mouth. The parotid secretions, they tend to dry up, and so the combination of this produces that the child also has a problem in swallowing the food which is given to the child. And rarely, in 10 to 20% cases, other salivary glands may also be involved. So if I have to show you a picture, this is a child with unilateral parotid swelling. The question will say something like this: unimmunized child, fever, with the photograph shown below where the tragus was lifted and the child was having irritability and pain. What is the likely diagnosis? First thing that should come to your mind is mumps. It can occur in adolescents and adults also, so adults can also have this kind of presentation. Coming to complications, the most common complication in case of children is aseptic meningitis. Sometimes the word meningitis is not mentioned, and so meningoencephalitis becomes your likely answer. Whereas in case of adults, the most common complication of mumps is painful epididymoorchitis, sometimes simply written as orchitis. So inflammation of the testis, epididymis and testis. So painful or tender epididymoorchitis. Again, epididymoorchitis, just like this swelling, it is mostly more than 80% cases, 85% cases, it is usually unilateral than bilateral, may sometimes cause testicular atrophy also. Fortunately, it is rare to occur in case of children. But complete sterility is not seen because one side testis is affected, the other side testis is still functional. And other complications of mumps related to the usual spectrum of mild encephalitis-like illness, which may not fulfill the features but may still have some altered sensorium, etc., precipitation of Guillain-Barré syndrome, and similar complications, ophoritis in case of females, they all have been described. Remember that pneumonia is not a predominant manifestation of mumps. If pneumonia occurs in mumps, that is highly atypical. So pneumonia, you can put a star and write somewhere that pneumonia is usually not seen. And treatment in case of mumps children, it is supportive. Just remember, the treatment is supportive. Nothing needs to be done. The child usually comes out of the infection. So next disease is infectious mononucleosis. Infectious mononucleosis is a febrile illness. It is a febrile illness seen in children, adolescents, and adults. So it can occur across the age groups. The causative agent, etiological agent, is Epstein-Barr virus, which belongs to, it is a double-stranded DNA virus belonging to herpes family. Epstein-Barr virus is the cause of infectious mononucleosis. However, remember, I'm putting a star, writing in bracket, MCQ point, infectious mononucleosis like illness can also be seen with agents like cytomegalovirus, toxoplasmosis, primary HIV infection, etc. There is a long list, but these are the major ones. Among them, CMV is considered to be one of the common reasons for infectious mononucleosis like illness. Now, when it comes to the mode of transmission, the mode of transmission occurs via transmission of oropharyngeal secretions, not nasal. It is the oropharyngeal secretions which have maximum concentration of infectious mononucleosis causative agent, that is Epstein-Barr virus, and oropharyngeal secretions contact will occur via close contact. Example, kissing. And that is why this condition is also called as kissing disease. The alternative name for this condition is kissing disease. Now, there is a very interesting, peculiar thing to remember here. In case of India, infectious mononucleosis is not clinically detectable in many cases, whereas the disease comes to medical attention more commonly in case of Western population. There is a reason for this epidemiological difference. See, Epstein-Barr virus is everywhere. The susceptibility in patients, in children and adults is also everywhere. In case of India, it is seen that the disease tends to occur in infancy and young childhood. And in Epstein-Barr virus infection, if they occur, the infectious mononucleosis occurs in a younger age, it is a milder illness. So many times it is simply passed off as a viral infection, and so the typical manifestations tend to be missed, or they are mild, so they don't come to attention attention clinically. Whereas in patients who are on the Western population, in those people, the infection tends to occur somewhere in the age group of adolescent period, 14-15 years till 25-30 years. And in this age group, the infection inherently is more symptomatic. They have higher chances of painful lymphadenopathy, they have higher chances of splenomegaly, and so they come to attention clinically more. And that is why, although if you see overall, the disease is prevalent across all continents, across all age groups, but comes to medical attention more in the Western world as compared to Indian population. This is something which is important. It has a PSM aspect to it, and in Vivas, sometimes examiners are fond of asking this question. This similar thing is mentioned in Nelson and Ghai also. So it is important academically for your exams as well. See, NEET PG we have to pass, but end of the day, we are all doctors. And so all these anecdotes, all these nuggets of information are useful for us because exams, studying is not only about cracking exams, it is also about being good doctors, being knowledgeable doctors. So wherever possible, without overburdening, I'm trying to give you small anecdotes related to what is mentioned in the books, not outside those. So this is regarding the mode of transmission of infectious mononucleosis. And remember that infectious mononucleosis has a tendency, Epstein-Barr virus has a tendency to cause latent infection, just similar to the other herpes group viruses as well. Now moving over to an MCQ Pearl. What are the conditions which are associated with Epstein-Barr virus infection? 3 to 4 MCQs have been asked on this in the past exams. So remember all these points, not even a single point should be missed. So first is infectious mononucleosis, second is nasopharyngeal carcinoma, third is Burkitt's lymphoma, fourth is Hodgkin's disease, fifth is your X-linked lymphoproliferative disorder, sixth is infection-associated HLH syndrome. HLH stands for hemophagocytic lymphohistiocytosis syndrome. HLH syndrome is a special topic which we have discussed separately in extra edge topics in this app itself. So you can have a look there, what I have discussed in brief 5-7 minutes about HLH syndrome. And it is associated with Alice in Wonderland syndrome, which is a DNB MCQ, old NEET PG based question. What is Alice in Wonderland syndrome? It is a neurological disorder in which there is altered perception of size and shape of objects. So just like Alice, you remember Alice in Wonderland, everybody has known about it. She falls into a rabbit hole and comes across a lot of adventures, a lot of organisms, a lot of people with altered size, shapes and appearances. Similarly, children, people, adults, adolescents who develop Alice in Wonderland syndrome, they tend to have either altered perception, like they will see their own face being larger as compared to what it is, or smaller as compared to what it is. They may see an elephant and consider it to be smaller than their own size. Or they may see a small mice moving around and they may visualize it in the form of the size of a dog. That altered perception, that altered distance, like the object may be like 20 feet away from them, but it will seem like the object is just placed in front of them and they may try to catch hold of that object. That altered perception, altered sensorium where the perception is changed, is called as Alice in Wonderland syndrome. There are two reasons for Alice in Wonderland syndrome. One is infectious, second is non-infectious. Rare causes, there is a huge list. For exams, remember, it can occur, non-infectious causes, it occurs in migraines. Infectious causes, Epstein-Barr virus is a common cause. So this is the MCQ poll regarding EBV infection. So continuing with our discussion, let us focus on the clinical features and diagnosis of infectious mononucleosis. Coming to clinical features, the typical features seen in infectious mononucleosis include fever, malaise, sore throat, along with lymphadenopathy, which is present in 90% of these cases. Lymphadenopathy most commonly involves the cervical region, although other lymph nodes may rarely be involved. Among cervical, posterior cervical lymph nodes are commonly affected. They are the most commonly affected. Others are also sometimes affected, but most common is cervical lymphadenopathy. In addition, among other manifestations, you can remember that splenomegaly, which is usually mild in nature, can be seen in about 50% cases. Hepatomegaly can be seen in 10% cases. And a rash with use of ampicillin or amoxicillin is seen in 30% of these cases. So these are the three things can be asked as standard one-liners for your entrance exam. How do you make the diagnosis? Among investigations, the screening test is done by a test called as Paul-Bunel test. Paul-Bunel test is also called as monospot test or heterophile agglutination test. This test is based upon the fact that many of these children, they have heterophile antibodies circulating in their plasma. When you use sheep or horse RBCs, they tend to agglutinate that. So it is called as heterophile agglutination test. For confirmation, we can perform ELISA to look for a IgM antibody directed against VCA, that is viral capsid antigen. Viral capsid antigen. Although not diagnostic, but another clue, when you do complete hemogram, you find that some of these children, many of these children are found to have raised total leukocyte count with increased lymphocytes. And many of these lymphocytes are atypical lymphocytes. Atypical lymphocytes are of which variety? They are of CD8 plus T cells, which have proliferated in response to the Epstein-Barr virus infection. So atypical lymphocytosis is seen in these children. Now coming to therapy, treatment in most of these children is supportive and slowly the patient improves. However, contact sports, for example, karate, wrestling, rugby, anything which involves significant physical or touch or pushing around, contact sports in children as well as adolescents as well as adults is contraindicated for at least 2 to 3 weeks after the infection because of risk of splenic rupture. And put a star, potential MCQ, what is the role of corticosteroids? Corticosteroids are used for 1 week. So we use prednisolone for a duration of up to 1 week if the patient develops coexisting complication, like if the patient has features like decreased platelet count, that is thrombocytopenia, if the infection from lymph nodes spreads to the whole pharynx producing a harsh if it spreads to the whole pharynx producing airway obstruction, or if the patient develops hemolysis producing hemolytic anemia. In these complications, you will use prednisolone in a dose of 1 mg per kg body weight per day for 1 week. Otherwise, it is a self-limited infection, self-limited inflammation. Potential MCQ prominently mentioned in books. What do you find typically on oral examination in these children? So you can write, put a star and add this point to your notes. You can put it as potential MCQ point. Oral mucosal examination in infectious mononucleosis will show the presence of petechiae at junction of soft and hard palate. Soft and hard palate. Potential MCQ for your exams. So this finishes the topic of infectious mononucleosis.